Hello, this is Sherry with the CGH Health Foundation, and welcome to our Growing Healthier Facebook Live program. These programs are designed to introduce important health topics to our patients and community, and also to introduce you to some of our providers, and you can get to know them a little better. Today, Dr. Bird is going to be talking to Dr. Preeti Joseph, who's the CGH neurologist, and Dr. Joseph is going to be talking about migraines and helping us to determine, whether it's a headache or a migraine, and some of the treatment options that are available and things like that. Next month's program will be on July 25th, and our guest next month is going to be Dr. Matthew Wolf, who is a family medicine provider in our Morrison Clinic. And Dr. Wolf has an interest in gerontology, and so he's going to be talking about managing falls and some other topics of interest to seniors in the home. So we're looking forward to that, and again, that will be on July 25th here on Facebook, live at 12 noon. I want to mention that the CGH Health Foundation campaign has kicked off, and as with last year, we are focusing on our dementia services, and some of those services include having a dementia navigator, that is Beth Stirk, who can help families to find resources, help to educate them when they're dealing with a family member or themselves who has a dementia diagnosis, and other things that we've done to establish support groups in our various communities for families that are caring for a loved one who has dementia. So that was our campaign focus last year, and we're continuing that this year, but also adding in a focus on our oncology. And under oncology, we do comfort care services for our oncology patients that include lunches and bags of useful items to help them through their cancer treatment. And that also encompasses our women's health program, under which we provide no out-of-cost mammograms and ultrasounds to women when they have their services done here at CGH. And then also rolling into our focus for next year will be our Ways to Wellness services. And that is a couple of social workers who help our patients to find services to overcome any barriers or obstacles that are keeping them from achieving their best health or getting in the way of their treatments or et cetera. So that's what we're doing at the CGH Health Foundation. If you would like to make a contribution, you can send it to the CGH Health Foundation at 100 East Lefevre Road in Sterling, or you can go onto the CGH website, which is www.cgh.com /giving-back. And so that's how you can make a donation. Also, I wanted to mention that the CGH Health Foundation and the CGH Auxiliary both have several scholarships that are available, and the deadline for applying for those is tomorrow. So just a reminder, if you've been holding on to an application, that you need to get those out. And that's all I have to talk about. We'll go ahead and turn it over to Dr. Bird if you're ready, Dr. Bird.
Why not? Sure. Thanks, Sherry. Appreciate it. Welcome, everyone. This is Bill Bird. I'm Chief Medical Officer here at CGH Medical Center. And today we are going to talk about headaches, in particular migraine headaches. And we have someone on who has been on our broadcast many times. Glad to have her back, Dr. Preeti Joseph. So let's have Dr. Joseph. Hi, Dr. Joseph.
Hi. Good afternoon. Thank you.
Yes, I don't know how many times, but you've been on here several times talking about things related to neurology. So
thank you for having me.
Yeah, you
love
bet.
to be here.
Yeah, you bet. So I'm going to get right at it, and let's start talking about. And we're going to focus in on migraine headaches. But before we begin to focus, the first question I have for you is, what are the differences in the symptoms of a patient who's experiencing migraine headaches versus other headaches?
So migraine headaches are probably worldwide the second most common type of headaches when they do studies. But when they look at what comes into a clinic or a medical situation, migraines are the most common. So typically it's one-sided. Generally, there's nausea and vomiting. It's usually throbbing or pulsatile. Sometimes you can have difficulty with sensitivity to light or sound or smell. And so those are the common features, the common characteristics of a migraine. Versus if you have a tension type of headache, which is the most common, you typically will have more of a dull type of headache. It's both-sided. It doesn't always have the throbbing. It's mostly a pressure feeling. It can come with neck pain and shoulder pain and other things. And then you might hear of cluster headaches. Some people will talk about that. Interestingly, across the medical literature, they say the percentage is less than 1% of actual cluster patients. And that will give you what we say autonomic symptoms. And autonomic symptoms are like a runny nose, your eyes get kind of red and bloodshot, you can have tearing, those kinds of things. So definitely a different situation as far as symptoms. So the most common is migraine. It comes on sometimes within 24 to 48 hours. Some people get vision symptoms to start. We call that an aura. Some people don't. And then you can progress to having a throbbing, usually one-sided headache. It can come with nausea, vomiting, those kinds of symptoms.
Thanks. So follow-up to that is, what actually causes headaches? In other words, what's happening in your, not headaches, but migraines. So what's actually happening in your brain that makes you have those symptoms, Dr. Joseph?
So that's still going on for research, but what they feel like is, the brain cells talk to each other with electrical stimulation. And so they feel like, researchers is who I mean by they, feel like there is all of a sudden an excitation or excitability, or the nerve cells get all, frazzled and what they say depolarized. So the electric currents change typically in one spot in the brain, which then triggers an inflammation. And that inflammation can spread and go out and affect what's called the trigeminal nerve complex. That's what goes to the face and the head and then cause the pain to happen. So there are various chemicals like CGRP, calcitonin peptides. There's other chemicals that are involved, serotonin, that all are playing a part in this whole process of a migraine. So it's an electric current in the brain in a particular location that becomes excited and then causes an inflammation, and that leads to pain.
Do blood vessels have any role in this?
That was the previous theory. We were under the assumption that there was some dilation and constriction of blood vessels. And recently they've felt less of that as part of the philosophy of migraines. And so that has changed to 10 years. There was a spasm of blood vessels that led to inflammation, and that all may still be part of the process, but they're dealing more with electrical, what they say, depolarization these days. But the ultimate result is still that there's an inflammation and things get really out of control when it comes to all of these chemicals being deployed in the brain, being released in the brain.
Okay. So how does one go about trying to prevent those chemicals from being released, short of medication, which we'll get to in a minute? But what can someone do to try to prevent that from happening?
So we know that women have a higher percentage of suffering or higher risk of suffering from migraines compared to men. And so hormones play a role. So sometimes if a woman consistently struggles with a migraine around the time of their period or when they ovulate, then, putting birth control on board, which is a medication, or trying to understand the pattern. But the common things to prevent a migraine are things like making sure that adequate sleep has been achieved, irregular eating, irregular sleeping, irregular hydration. Those are probably the top 3 that can contribute to a migraine. For some people, there's sensitivities to various foods. So nitrates that are often used as preservatives in like deli meat and hot dogs can cause a lot of patients to trigger a migraine. Red wine, the flavonoids, those chemicals can trigger a headache. So alcohol in general can sometimes be a trigger, but sometimes it's red wine in particular. It can also be triggered if you're stressed. Emotional distress is probably one of the key factors. And sometimes you can't control that, but know and understand that maybe you're more susceptible to a migraine at times where you're under a lot of emotional stress. So ways to treat headaches beyond medications, trying to make sure that you control what you can control. So trying to get an adequate amount of sleep, 7 to 8 hours, trying to make sure that you're hydrated, drinking at least 60 ounces of water or liquid that's not caffeinated and not, full of other chemicals during the day. So milk, juice, water, those are appropriate. Trying to make sure that you manage stress, trying to find ways to relax your body and your brain and your muscles. And then, of course, evaluating to see what triggers could be a possible factor in the migraines that you're experiencing or someone else is experiencing.
Sounds good. My guess is that a good percentage of the patients, by the time they get to you, they've probably tried the things that you just talked about. And despite all those things, they're still having enough migraine headaches that they need to see you, a neurologist, who can try to help them with those issues. So can you talk to us about what medications to start with that you can use to help patients out? First, let's two lanes here. One, to prevent headaches, these migraine headaches, and what medications are out there nowadays to, I guess the word would be like abort them or stop them in the middle once they start. So that's a lot of stuff there, and I'll leave the floor to you here on that.
Sure. So migraine treatment has changed in the last, I'd say 7 to 10 years, but for prevention. So we share medications from various categories. We use, first of all, we use over-the-counter medications, sometimes to prevent and to treat, but that's more of a treatment type of class. But we share medications for prevention. So we use antidepressants, we use blood pressure medications, and we use anti-seizure medications. And we have certain drugs, certain medications in each of those classes that we use to treat a headache, to prevent a headache, and do very well with that. Now, there's also a new class of medication called CGRP inhibitors, and that stands for the calcitonin. It's a calcitonin gene-related peptide. And so that particular class of medication is brand new on the market, probably 6 to 10 years at the most. And that group of medications are just meant for migraines and for headaches and are unique to just neurology in the headache world, not necessarily neurology. So when we talk about prevention, one of the first drugs that we will start with is evaluating and looking, is there anything else? So if someone is having difficulty with sleeping or having some difficulty with emotional stress, sometimes we will pick a medication like amitriptyline, which is a form of medication in the antidepressant class, but it actually does a much better job when it comes to headaches than treating depression. We also have what's called an we have SSRIs, we have SNRIs. These are categories for antidepressants, and venlafaxine or duloxetine are medications that sometimes we will use. We'll use blood pressure medications like metoprolol or propranolol. We will also use seizure medications like Depakote or Topamax. These are common medications. Now, this new category of medications to prevent a headache, we have several forms of it. We have a tablet, and the brand names are what I'm going to say because it's sometimes hard. It's a mouthful to remember both the brand name and the generic name. But Qulipta, starting with the Q like in Queen, is an oral medication that's taken every day. That's part of this new class of medication. We have 3 injection medications. We have a drug called Aimovig. We have Emgality. We have Ajovy. Those medications, 2 of those are injected monthly. 1 of those can be injected every 3 months, so that's nice. And then we also have medications that are orally dissolving that can be used in prevention. And that medication is just put on the tongue, and it's allowed to dissolve, and it's called Nurtec, and that will also help in prevention. And then finally, we have an IV medication that's available to help with prevention called Vyepti. It comes in 2 different doses, and that medication is available and given at CGH, CGRP, too many acronyms, CGH, and it's done every 3 months as an IV infusion. So there are many options to help with prevention and help treat and control migraines. It varies depending on what other situations, what other conditions someone might have as to which option that's chosen. And of course, insurance. So traditionally, most insurance require use of one of the 3 older categories of medication, such as the antidepressant or the anti-seizure medicine or the blood pressure medicine, before we're ever able to try the newer class of medications. So all of those factors play a role in what is chosen to help prevent. But the good news is we have lots of options.
Are those ones that you rattled off that have the brand names? Some were like put on your tongue, some were IV, some were injections. Those are all in that same class of medication? Okay.
That is correct. Yes, they're all, you'll hear the common term CGRP inhibitors. They're all in that same class. And so they're really tailored to what somebody wants. And really sometimes one is more effective than the other. There are people who really don't want the nuisance of having to take a pill every day. So they'll do an injection once a month or once every 3 months. And then there are others that say, I don't even want to do the injection. I would rather come in, get my IV, get it done every 3 months and live my life. And so it really is dependent on what else is going on and what the patient prefers and what the insurance will allow at the end of the day too.
How effective are those new medications, Preeti?
Oh, they're fantastic. And so there are more and more insurances that are allowing it as first line, but it's going to take some time in order for it to catch up with every insurance company. So they are newer, they're more expensive. And so therefore insurances are trying to be cost effective and trying to avoid going to those before trying some of the older class of medications, which are still really effective. So, but the new group is great. It's especially beneficial to patients who might have side effects. So for example, some patients are already on an antidepressant that's effective. So I don't want to choose yet another antidepressant to add to prevent migraines. Some of my patients may already have blood pressure medications or have a low heartbeat. So I don't want to give them a medicine that could, interact with that. And finally, there may be patients that are of childbearing age or just simply cannot take an anti-seizure medication for one reason or another. And so then I want to avoid that. And the other category I do want to mention is that there are separate medications that we use for pregnancy or if you're actively trying for a pregnancy, because we want to make sure that not only is the patient safe, but the future baby is safe also. So those are different medications, and we're very careful. This new class of medication at this point hasn't been studied enough for us to use during pregnancy. And actually, the final thing I do want to say is we do use Botox. I actually forgot all about that. We do use Botox for prevention of migraines, and that's every 12 weeks. There's an algorithm, there's a set pattern, there's a recipe, I like to say, on where those injections are done, and that's extremely effective as well.
So depending on where your headaches are or where you would get the Botox injection?
No, it's actually a set FDA approved location. So it's done in the front. It's about 31 injections front, the temporalis sides of the head, the back of the head and the occipitalis, the base of the neck, and into the shoulders. Okay. So it's a very, very studied pattern of where to give the injections. However, I always request that if somebody's going to try Botox, they try it twice, because the very first time you have the injections, there's a lot of, fear, concern about how is that going to go? How's it going to feel? There's a lot of stress associated with this sometimes for a lot of people. And so I say, give it 2 options, give it 2 tries. And then if it doesn't work, then we don't go through that again. If it does work, but somebody says, well, I'm having a lot more pain in the front of my head, we'll do extra injections in the front or in the shoulders or wherever. So we can be a little more flexible after the second injection series. We can add on, I should say, if needed. If certain people are just really bothered by their neck, then we can always add more injections there. So that's a very good option. And sometimes, there are studies for pregnancy. So far, it's been found safe in pregnancy. So that's another option that we can use in pregnancy if needed.
Is it all 31 injections at once in one setting?
Yes, and it takes about 5-10 minutes to do in the office. I do it. We've been doing it for years. We have a number of patients that come in and get that done.
So you could see, you'd be able to identify those patients because they have a nice smooth forehead, or is that?
And hopefully no bruises and no. The biggest thing is typically it really is very well tolerated. It takes about a week to 10 days, I say, to kick in. And in general, the effect lasts for 3 months. So patients just love it because of that. But more than that, if you come in and get the injections, it sometimes looks like you have tiny little bug bites, especially on your forehead, until, that goes away. And you can, within an hour or so, you can wash your face, you can do whatever you need to do, live your life, take a shower, all of that. So it's really pretty easy. I have patients that have come in. I mean, we kind of count the number of sessions. I don't know, probably my most sessions is in the 20s now, their injection series. So there are some patients that absolutely feel like that's a great option for them.
Yeah, it's so interesting that, like, what you talked about, what causes these migraines in the earlier part of our conversation. That like something that you're doing with Botox is calming the smooth muscles has some way or another that it's affecting inside your neurons. It's so like, okay, all right, more to find out about all that.
Yeah, and I think that's where it's becoming, it's always been a challenge. Years ago, we used to never even think migraines were a medical issue. They just said, oh, you have a headache, it's fine. And then as more and more research has been done, the explanations keep changing, and why certain things work and certain things don't, I think helps it evolve as far as why they feel like this is happening in the first place.
So you had, here's a question. Are there any correlations between headaches and stroke, mini stroke? Can bad headaches be a warning sign?
Yes. So, there are things to look for to make sure. So if you are younger than the age of 50 is what the data says, if you've had repeated episodes of headaches that follow a similar pattern, it's very unusual for it to be anything more serious. If you get older than age 50, you have a sudden headache that is completely different than maybe anything you've ever had in the past, or you've never really had headaches and all of a sudden have a headache. It could be positional, where it's not really there all the time, but it's only in certain positions. Or if you have any other associated symptoms, so if you have numbness or weakness or anything else that all of a sudden changes, that needs to be looked at for a TIA or a stroke. There is a slightly increased risk in patients who struggle with migraines for TIA and for stroke. But in general, most of the time you can tell the difference. Most of the time people are able to say, okay, this is my usual migraine pattern. So warning signs are if something is just different from previous episodes, if something is more severe, intense, I think that definitely needs to be checked out with a brain scan and with a professional.
Sounds good. And then you were going to talk also about drugs for to treat that when we try to prevent migraines, but when someone actually has a migraine, what are the drugs that you're using these days to try to help patients out?
So one of the things that I will always say is if you're doing everything that you can do, is to try over-the-counter medications first. So if there's a way that you can try Tylenol or ibuprofen or naproxen or a combination drug like Excedrin and see if that will work within 30 minutes to an hour, if things are starting to get better, then that's great. And you don't need to move on to anything prescription strength. But if those kinds of things are not helpful in the past with previous experiences, or you're not able to take those kinds of drugs for one reason or another, there is a lot of option these days. So Traditionally, we've had drugs on the market called triptans, and triptans are called that because their generic names have those letters in them. So we have sumatriptan and elatriptan and naratriptan and frovatriptan and rizatriptan. So they're all medications, and those medications have been the main drugs that we have used for years and years when it comes to stopping a migraine. And the philosophy, the idea behind that is that there is some dilation and spasm of blood vessels that go along, even with all the new theories of electrical changes. And so the medications constrict and try to hold steady the blood vessels, try to reduce the inflammation, and help resolve the headache. And those medications come in tablets, they come in nasal sprays, they come in injections, they come in a variety of options. Some of those drugs take a long time to kick in. Some of those kick in faster and then wear off faster. So there's a combination of those that can be tried. If one doesn't work, don't get discouraged. Others can work. But there's one thing that you have to be careful of. Those medications cannot be used if you have a variety of migraines that cause you to become paralyzed, a hemiplegic migraine, or if you have any kind of what's called brainstem symptoms, where you get numb or weak or anything that is concerning for areas that could potentially cause more problems. If you have heart disease or have had a heart attack, you cannot use the triptans. And so those are kind of the common things to watch for. And my senior adults, I'm a little more careful with that category, because if part of the way the drug works is to constrict and narrow and hold things steady, it's not just going to do that in the brain. Whoa. It's going to...
We can still see you, by the way.
Okay, I am logged out.
Yeah,
So
yeah, you're good.
Talking.
Keep talking. You're good. You're good.
So it's gonna, I can't think of where I was, but it's gonna narrow blood vessels, not just in the head, but it's gonna narrow it in the heart. So we have to be careful. In a rare situation, someone can take the medication and have other issues developed as a side effect. Common side effects of the medication: you will feel chest pressure, you'll feel jaw pressure and tightness. Those are all normal symptoms of the medication. So triptans are one class of medications that we use to stop a migraine. The second class is this new category called CGRP inhibitors. And so there are medications in that are designed to stop a headache. And so there are drugs that come in two different doses. There is Nurtec, which we talked about as prevention, but it's also available to abort or stop a headache. And it's only given, you just have to put the dose right on your tongue. It dissolves, it lasts for 2 days. So the effect lasts for 48 hours, which is really nice for people who struggle with a cluster of headaches and migraines. There is a nasal spray called Zavspret that is used. That's extremely effective. And that's also part of this new class of medication. So these are options that we have. We have a drug called DHE, or dihydroergotamine, that's probably used less and less. I rarely use the medication because it is a good medication to stop a headache, but it has to be given IV or intranasal. But I also have to be careful about whether or not you're pregnant, and I've got to monitor your EKG. And so it takes a lot more steps. It comes with potential side effects. And so I'm not using that much in this day and age. And then finally, there's a new drug on the market called Rayvow, lamsitidine. Don't hold me to how I'm pronouncing that. But it's a medication that can be used even if you've tried one of the other medications. And it's a unique way of helping the brain stop the migraine. Generally, I will say take it at night. If you're still having a headache by the end of the day, you've tried other things, take it at night, go to sleep, because you cannot drive or operate heavy machinery for 8 hours after taking that medication. And so if you can go to bed with that medication, that's another great option. So lots of potential tools in our tool belt, so to speak, and lots of options to try and help stop a migraine. And then, of course, if things get really out of control and still, are struggling and suffering and not having any relief, we have IV options. We can do IV magnesium. We can do IV Depakote. We have other things that we can do, IV steroids, dexamethasone. All of these things can be used. And then finally, we get a lot of nausea and vomiting with migraines. And so we often use what we say antiemetics or anti-nausea medicine along with some of these other drugs to help the brain resolve and end the migraine.
Do you find that these newer drugs are? Oh, I got a question here from Diana. Okay, you can read that. Feverfew. What would you say about that question there, Preeti?
Oh, I think the name. I think I wrote it somewhere, but yeah, the riboflavin for sure. Feverfew. Some of these things have some data behind it. Butterbur root is what I was thinking about. For some to try the 6-month trial, and if not improving, then move on to another prevention. So there is good data on things like magnesium, 400 to 800 milligram daily for prevention of migraines. There is good data on riboflavin, which is vitamin B2. You can take 400 milligrams of that, and that seems to help. I think Butterbur is 50 to 100 milligrams twice a day. So there are some natural options that can be tried, and I have no objections to that. I think it's always nice to use what's out there, but try it. If things are not improving after about 6 months, then I think it's time to move on.
Great, thank you. Thanks for the question, by the way, Diane. The thing I was starting to ask you, Preeti, is are these newer classes of medicines more effective than the triptans, or are they similar in terms of their effectiveness for stopping a migraine headache?
Well, at least in studies, we know it's as effective. I feel like they're better only because they have fewer side effects. So the side effects of triptans, of course, the ultimate side effect is you could have a heart attack with the constriction of the blood vessels with that medication. And so you have to be very cautious, but it works really well. And it's mainly for older adults. So I really say if you're over 65, I'm very careful about that class of medications. But the newer medications have a few side effects, lightheadedness, dizziness, some drowsiness, but really they're extremely well tolerated and they don't interact with any other medications. I don't have to worry about kidney function or liver function. And so it's fantastic to be able to feel comfortable not having to micromanage a patient and their medications and be able to say, okay, I feel comfortable and I feel like this is going to be safe for you to try. But they work very well. The nasal spray, Zavspret, works extremely well. It's got a horrible taste. So if somebody takes it, they may just be miserable with the taste, but their headache, almost most people in studies within 2 hours are so it's very nice to have. Very few side effects, very effective.
Good. One final question for you, and then I'll let you go. Is the goal of treatment of migraines to completely eliminate them, or is it to more manage and control so that you have fewer and the ones that you have are milder? You know what I'm saying? Are you hoping when you see a patient for the first time, you know what, sir, I'm going to be able to, your migraines are never going to happen again? Or is it more like you're going to have migraines, but they're going to be, here's how they're going to look?
Yeah, so I think it's twofold. I think our ultimate goal is that you don't ever have a migraine, but none of us can control our emotional, stressors. None of us can control sometimes, if the sleep level or if we get an infection or we don't feel good for whatever reason. But the hope is that at least your headaches are not disruptive to your daily life. You shouldn't have to leave work or you shouldn't have to leave an activity with friends and family because of your migraine. And I really feel like the goal is for a patient to be able to be in charge of their headaches and not their headaches be in charge of them. And so trying to treat so that you can quickly recognize. So the key to migraine treatment is speedy treatment. So the faster you can treat with the medication, the quicker, the more likely that the headache is going to resolve. I always describe it as like a fire. It starts in one spot and then it spreads in the brain. So if you can treat something where it's a fire in one spot, it's a lot easier to treat if you can get to it quickly. By the time it becomes a forest fire, it's much harder to treat. So it's recognizing what is the pattern for the migraine. It's treating as quickly as you can, trying to avoid your risk factors, trying to maintain hydration and sleep, and trying to make sure that you're eating properly. You've gotten an eye exam at least every 2 years, preferably once a year, just to make sure nothing's changing there. And then being able to recognize that you're having a headache, take the medication. If you're having more than 2 days of headache per week, it's time to talk to your provider about a prevention medication. Because one of the things that I see frequently by the time they get referred to my clinic is analgesic overuse headaches or medication overuse headaches. So if your body gets used to seeing large quantities of Tylenol or certain medications all the time to treat a headache, your body gives you a headache so you can keep giving that chemical to the body. So it's almost like your body becomes addicted to that chemical. It's like the people who drink a pot of coffee every day. If you don't have a coffee, then you're going to get a headache. And so trying to understand that you shouldn't be spending your life dosing with all these medications over the counter for your headache, trying to make sure you recognize your risks, trying to treat effectively and immediately so that you're back to life within an hour to 2 hours. That's the goal. And hopefully, ultimately, never having a migraine, but that's not realistic.
Great. Hey, as always, it's really good having you answer all these questions. I know we could talk for a lot longer about migraines, but I feel like we've hit a lot of the key topics here for migraines. And thank you so much for your time, Dr. Joseph. It's great to have you on again. And I'll be asking you again to come back. So
always happy to be here. Thank you for having me.
Thank you. Appreciate it.
All right. Bye.
Okay. We have a few shout outs and other things we wanted to. So I want to congratulate Jody Rank. Jody is our employee of the month. She's a physical therapy aide here in rehab services, and she works here in the hospital with patients. And Jody's always a ray of sunshine whenever you see her. So congratulations to Jody. And congratulations to Quan Kendrick. Quan won the Above and Beyond Award for Illinois Home Care and Hospice Council. So congratulations to Quan on that recognition. By the way, Quan works in our home health care for CGH Home Health Care. And then also want to just highlight that July 25th, we are going to have another Facebook Live with Dr. Matthew Wolf. Matt's going to be talking about managing falls in the home. So looking forward to that. Put that on your calendar. And Matt's always a fun guy to talk with too. All right, that's all I have for this week. Thank you so much for watching. If you enjoyed it, share it with others. Until next month, thank you and bye.